4, 3, 2, 1. Sir, we are live now.
Good evening, everybody. Welcome to today's evening webinar brought to you by the Orthopaedic Research and Education Foundation India through Ortho TV. Today we have Dr. Ratnesh Singh from Paras Hospital, Patna, who's going to talk about basics in shoulder arthroplasty. I think this is an area where there's been a lot of development and certain basic importance to the tuberosities, the prosthesis, the retroversion, etc., need to be properly aligned to get a good result. So I think without much ado, I'll hand it over to Dr. Ratnesh to give his talk on shoulder arthroplasty. Over to you, Ratnesh.
Thank you, sir. Yeah, good evening, everyone. Are you able to see the screen?
Yes, sir.
Okay. Good evening, everyone. Today I shall discuss about the basics of the shoulder arthroplasty. So, for the sake of description, I have divided this into the three types: hemiarthroplasty, total shoulder arthroplasty, and reverse shoulder arthroplasty. We are basically talking about the replacement arthroplasty here. So, in all these types, few things are common. One is the preoperative planning. For preoperative planning, you should first take the X-ray, AP view in the scapular plane, that is 30-degree oblique view. In this view, you can see the fracture pattern or even the arthritis. You can see the glenoid condition and the proximal migration of head. You can appreciate on this AP view that can give you an idea about the condition of the rotator cuff. And the axillary view is taken just to assess the glenoid bone stop, and also you can assess the retroversion of the glenoid. CT scan is helpful in identifying the fracture pattern, fracture geometry, whether it is operable with fixation or by arthroplasty. You can also assess the glenoid bone stock better in the CT scan and also the retroversion. You can also assess the size of the head if you are planning for replacement of the head. And whenever there is a doubt about the condition of the rotator cuff, like if you see the proximal migration of head, or there is impingement sign on clinical examination, or if there is any doubt, you should go for the MRI. And over the MRI, you can check the status of rotator cuff. So it will help in planning to go for the hemi or the other kind of arthroplasty. For the surgical approach, deltopectoral approach is taken usually, and the position is B-chair position. It gives good exposure, and you can move the arm very freely. So drape the patient as it is shown in the picture, and your C-arm should be able to take the picture. So this is the usual OR condition, what is required for this shoulder arthroplasty. Now coming to the hemiarthroplasty. So what are the indications? So most common indication for which we are doing the hemiarthroplasty is the proximal humerus fracture, especially the 3-part, 4-part fractures, especially if the bone condition is poor or highly osteoporotic fractures. You may think that your fixation is not going to help, that could be failed. So go for the hemi replacement. If there is head splitting fracture or the fracture with significant destruction of the articular surface. In primary arthritis, you can go for the hemiarthroplasty, although this is not the preferred treatment, but still it is advisable where the glenoid bone stock is adequate and when there is high risk of glenoid loosening, especially in young patients on active laborers. You can do in also in the rotator cuff arthroplasty, although nowadays reverse shoulder arthroplasty is preferred, and you can do in the avascular necrosis, osteonecrosis of the head. This is the usual indication for which hemorrhoplasty is done. So coming to the steps. So first the head osteotomy. First the joint is opened through deltopectoral approach. Capsule is excised, capsule is cut, and the joint is opened. You can either elevate the capsule and subscapularis over the bone, or you can do the osteotomy. Results of both the procedure is almost similar. So after you open the joint, go for the head osteotomy. Head osteotomy is started just medial to the supraspinatus insertion, and it is cut in the retroversion of about 30 degrees. So it is easy to get when you just externally rotate the arm by 30 degree and cut the head in the sagittal plane, you will achieve the 30 degrees of retroversion. Now the canal preparation is done for the stem, and the trial is done. Now for the trial, you have to decide the head height. So head height should be 7 to 8 mm if of greater tuberosity. If it is preserved, or when both are fractured in 3-part, 4-part fractures, then in that condition, you can take the reference from the insertion of upper margin of pectoralis major, from where it should be at least 6 centimeter above the upper margin of pectoralis major, or if the patient is tall, you can take up to the 7 centimeter above it for better tensioning of the joint. And head size determined by the opposite side head measurement on X-ray, or you can do that on CT also, or you can, if the head is preserved, you can directly measure on the resected head. Stem size according to the reaming, and final implantation with the cement. Cemented hemi is still the gold standard. All the newer implants came up with the uncemented version. Then you go for the tuberosity reduction fixation with the shaft. If it is the fracture scenario, there is special technique that is developed for the tuberosity reduction. You have to pass the sutures through both greater and lesser tuberosity, and on the stem there are some pores over which you can anchor these two tuberosities and tie over each other, and you also have to bind this with the shaft. So first the drill holes are made, sutures are passed, then the stem is cemented, then both the lesser and greater trochanter tuberosities are bind together, and then they are tied to the shaft. And the area, the remaining area and the bone deficit is filled with the bone graft, which is taken from the head, which is excised during the procedure. Now coming to the rehabilitation of the hemi, especially in the fracture situation. So passive assisted motion for first 6 to 8 weeks. Here you can advise in the pendulum exercises or circumduction. Even you can passively stretch, abduct the arm to some extent. But active abduction and strengthening exercise only after proper healing of the tuberosity, which is usually 6 to 8 weeks, which usually takes 6 to 8 weeks, depending upon the fracture pattern. Now coming to the complications. So most common complication is glenoid lysis if it is done in young active patient. So the treatment is either you go for total shoulder arthroplasty or reverse shoulder arthroplasty, depending upon the condition. Tuberosity, malunion and non-union are also a common problem, and they need to be addressed because that leads to the stiffness and decreased range of motion. So the treatment is repositioning of the tuberosities, and the bone grafting is done for the healing. Instability could be present if there is a deficiency of the rotator cuff, or if there is deficiency of the acromion arch, that can lead to the anterior superior migration of the head. And the infection is definitely, there is chances of infection about 2% in cases of hemiarthroplasty. Now coming to the total shoulder arthroplasty. So it is technically the resurfacing of glenoid it is a technically the resurfacing of the glenoid with the head replacement. So cemented all poly is the gold standard, and it has good survivorship is required in total shoulder arthroplasty. So it leads to the point stress or high shear forces that can lead to wear and accelerated lysis of the glenoid component. So what are the prerequisites for going for the total shoulder arthroplasty? You should have a good intact and functional rotator cuff. That should be checked clinically as well as you can check by MRI whenever there is some confusion. And good glenoid bone stock is required. So coming to the indications, most common indication for total shoulder arthroplasty is osteoarthritis. Less common are rheumatoid arthritis, post-traumatic arthritis, avascular necrosis, and severe femoral head fractures. What are the contraindications? So contraindications are tear or non-functional rotator cuff. Like if you see the proximal migration of head on the X-ray, you should go for the reverse shoulder arthroplasty rather than total shoulder arthroplasty. Insufficient glenoid bone stock. If you see the erosion of glenoid up to the coracoid process on the AP X-ray, it is a contraindication for going for the total shoulder arthroplasty. Rotator cuff arthropathy is also the contraindication where you have to go for reverse shoulder. Active infection and brachial plexus injuries are the contraindication where you have to wait for it to heal or recover. Now, what are the complications of total shoulder arthroplasty? The complications are glenoid loosening is the most common cause of total shoulder arthroplasty failure in osteoarthritis. Stem loosening, it is more common in rheumatoid arthritis and osteonecrosis condition. Instability, that could be either due to the soft tissue imbalance or that could be either due to the component malposition. Chances of infection is there. Periprosthetic fractures could happen during the surgery, especially in the female patients. They have narrow canal, and if the ramming is not done properly, there is high chances of intraoperative fracture periprosthetic. The rotator cuff injury, that could be iatrogenic at the time of surgery, or that could be the attritional over the time. That can be seen. You can see the head migrated proximally and anteriorly on the X-ray. Stiffness is also a very common complication of total shoulder arthroplasty, and axillary nerve could injure during the surgery. Now coming to the reverse shoulder arthroplasty. Reverse shoulder arthroplasty is also the type of total shoulder arthroplasty. Both the surfaces are replaced. The difference is here that the glenoid is convex hemispherical wall rather than head, and the humerus is concave articular surface. That is why it is called reverse shoulder arthroplasty. The main indication is deficient deficient but the indications are broadened gland retention in the 10 years survival. So what are the indications? The most common indication is cuff arthropathy. It can be done in the failed total shoulder arthroplasty, arthritis with deficient cuff, and 3-4 part humerus head fracture. So here I would like to point out one thing, that if there is tear of the supraspinatus or that is not retracted, or if the calf can be repaired, then you can go for total shoulder arthroplasty also. If calf is irreparable, then you should go for the reverse shoulder arthroplasty. What are the contraindications? So axillary nerve dysfunction is the contraindication, because which is the main. Then coming to the deltoid deficiency. Global deficiency is a contraindication. Partial deltoid dysfunction is relative contraindication because reverse shoulder may give reasonable result, especially in terms of pain relief. Acromion deficiency is a contraindication. Glenoid osteoporosis with high chances of fracture both intraoperative and postoperative. An active indication, active infection. Now coming to the biomechanics of reverse shoulder, which is changed when we do the reverse, when we reverse the surfaces. So what happened in reverse shoulder arthroplasty? The center of rotation is both medialized and distalized. So this leads to both the advantage and disadvantage. The advantage of this is that increases the deltoid abductor momentum because deltoid is the main muscle which is responsible in absence of rotator for the abduction and forward flexion of the shoulder. So reverse shoulder basically rely on the function of the deltoid muscle for abduction and forward flexion. So if we distalize and medialize the center of rotation, it increases the deltoid abductor momentum and that decreases the fatigue of the deltoid. And there is also decrease in the shear forces through glenoid bone implant interface. Here is the constrained articulation with the fixed fulcrum for humeral rotation that leads to the stable prosthesis and become more effective in forward flexion. But there are some disadvantages of this medialization of the center of rotation. One is there is decrease in rotator cuff muscle tension that leads to impaired internal external rotation. Even in rotator cuff arthropathies, even in the tier of the supraspinatus and infraspinatus, the internal rotation and external rotation, even in the this reverse shoulder arthroplasty, actually rely on the function of the rotator cuff, mainly on the rotator cuff, because deltoid doesn't help in internal external rotation. So if it is decreased, there is impaired internal and external rotation. And second and most important thing is the scapular notching. This scapular notching due to medialization of the humeral component leads to the polywear, and that leads to the lysis, and also that can lead to the stress structure of the glenoid. Now, what are the complications? So, scapular notching, it is one of the major cause of failure, early failure. Glenoid loosening. Scapular notching can lead to glenoid loosening, deep infection, acromial or scapular spine fracture, and neuroplaxia of axillary nerve is common. Complete axillary nerve injury is relatively rare. There are some universal shoulder prostheses that can be used. Here you have the option of changing to the reverse shoulder to total shoulder or total shoulder to reverse shoulder on table also, because they have the common stem and common glenoid component that is available with the FH Orthopaedics. I think this system is not available yet in India. So this is the conclusion in this what should be used. This is the table where you can find in the short description what implant should be used. So I'm concluding my talk here. Thanks.
Thank you, Ratnesh. I think we should open the session for questions.
Thank you very much, sir. So while we are waiting for the question, you have told acromion deficiency as a contraindication for reverse shoulder arthroplasty, right? So, sir.
Acromion deficiency actually can lead to the fracture if it is not, because it relies on the power of the deltoid muscle that is attached to the acromion also. Actually, in reverse shoulder arthroplasty, there is some lengthening of the deltoid muscle. So always it is in stretch. And there is also chances of dislocation.
That one thing what we have heard is like in total shoulder arthroplasty, like glenoid component loosening is quite common, but when we do the reverse shoulders, why it is that complication is usually not there? What is the difference between the mechanism of these two?
Two mechanisms is here. First is when we do the total, the surface is less conforming. So point stress is more. So there is high chances of loosening, and stress confined to actually the joint is not conforming. So forces are not distributed equally during the range of motion. So point stress is high. That leads to loosening and also the wearing of the component. And in reverse shoulder, it is kind of more conforming like that in hip of the muscle. You see, the hip. The one surface is almost conforming to the other surface. Forces are distributed equally. And second thing, the medialization, the stress also decreases on the surface. Recent trend is more towards a reverse shoulder arthroplasty rather than total shoulder arthroplasty.
Yeah, I think in trauma for the younger, meaning say it's a 50, 55, close to 60 year, then it depends on the fracture pattern. If it's a very high fracture with the multiple combination head split elements, then you may decide on a hemiarthroplasty. In the older patients, there are two factors. One is the level of the fracture and the amount of osteoporosis and the condition of the rotator cuff, because some of them have very poor rotator cuff as it is. So even though you do try to reattach the trochanters, even in the reverse shoulder today, the chances of hemi or a total shoulder functioning satisfactorily is reduced because of the problems with the rotator cuff. So that would be the indication to not do a shoulder replacement, hemiarthroplasty, but go straight to a reverse shoulder.
There is one question asked by Dr. Sachin. Is there indication of age for total shoulder arthroplasty and reverse total shoulder arthroplasty? What is explaining, sir? Or we do both in young patient also? So I think
in younger patient, the more and more suggestions is towards going for the hemiarthroplasty that can later can be converted into total or reverse shoulder.
Yeah, I think the reverse shoulder, we still don't know the long-term results of them, especially down after 10 years. So a lot of them get weakness of the deltoid. The newer designs are supposed to reduce that problem, but we still don't know the answer to that, because if you saw the original designs for the reverse shoulder, they were designed to stretch the deltoid out, give a bigger lever arm to the abductors so that the abductors could take over the function of the tuberosities, so of the greater supraspinatus. So the initiation of abduction could be done by the deltoid itself. Now,
sir, how
yeah.
yes, sir.
How much external rotation, internal rotation is compensated in this reverse shoulder arthroplasty, sir? Is it that much or is it acceptable, sir? Like,
What do you mean?
Actually, it depends on the condition of the rotator cuff, because for the rotation, it depends on the integrity of the subscapularis and infraspinatus muscle teres minor, mainly for.
So even with a reverse shoulder today, you would try to restore the tuberosities. Okay. In the initial days of reverse shoulders for trauma, people used to ignore the tuberosities, saying that this is designed to work without the supraspinatus functioning or the rotator cuff functioning. But they found that the prognosis for the reverse shoulder improves if you also get the tuberosities restored and the rotator cuff restored.
So there is another question asked by Dr. Neeraj Raj, that what is rocking horse phenomena and measure to avoid it intraoperatively, and about the treatment of that rocking horse.
Rocking horse is basically the opening of the joint. Suppose you move internal rotation and external rotation. It both moves and translate. Fural component both rotate and translate over the glenoid component. So when we move, there is chances of opening from one side. This is the phenomena that depends upon the actually tension of the rotators. That is mainly important. Repair and tension and proper sizing of the component to make the rotator cuff tension proper. Depending upon the choosing, suppose it's too tight, that may lead to the opening from one side. If you choose a larger size glenoid component, that can lead to the opening up from the one side.
So, as you have mentioned about that, if deltoid is not intact, then we can't do the reverse shoulder. In that case, sir, or axillary nerve is it is not working.
There's two main indications for doing it. One is definitely one and foremost is the relief of pain, and second one is function. So pain relief is good. Even the deltoid function is not 100%, you will get a good pain relief. But range of motion would not be as good if your condition is not good. Means condition of the deltoid is not fully functional. So even if the deltoid deficiency means in absence of deltoid, in presence of deltoid, in complete deltoid paralysis, it is of no use definitely. But if some functions of deltoid is reserved, at least pain relief could be there, because the arthritic conditions are very painful. Function may not, you may not achieve the good functional result, but at least pain relief could be there.
So, any addition over?
No, I think that's if you if the reverse shoulder depends on deltoid function. So if the deltoid is completely paralyzed, then that would not be a good indication for a reverse shoulder. Because if mild amount of weaknesses, it can compensate, but not if it's a complete paralysis of the deltoid.
So, if reverse shoulder fails, then is there any other option, or do we?
Any reasons?
So I think the options are limited to revising the reverse shoulder. You can revise it, or the only other option is to remove. I mean, like if it's infection or something, you remove everything, put a spacer, cement spacer, and then if you can control the infection, think about doing it again. Arthrodesis becomes very difficult because you've already taken out the head and part of the glenoid. So doing an arthrodesis becomes very difficult, but that may be an option.
So, one thing about the techniques are like how to check for the retroversion, that it is
I
retroverted.
think he mentioned it. I think so. Your average retroversion is how much?
Usually 20 degrees shoulder approximately.
Well, maybe 25 to 30 degrees or 20 to 30 degrees. So you have to try and re-establish the same relationship. Okay.
So,
You can measure it directly on the setting, even on the axillary view.
Pardon?
We can check it on the city, directly measure on the city, or even in the auxiliary view, we can measure it.
You can check on CT, but clinically, at surgery, you're clinically trying to usually aim for around 20 to 30 degrees.
Yeah.
Obviously, you have to need to check what position it's stable in the shoulder, in the glenoid as well. Okay,
so I think there is no more question in the chat box, sir.
Sure. Okay, I think if that is all from the question point of view, we will call it an end. And thank you, Ratnesh, for a very clear presentation. And until next week, bye everybody.
Thank you very much.
If you ask them to stop doing the live transmission.
Yeah, sure. Will do.
Yeah,
We are still live.
yeah, I know. Ask him to stop the live.
Presentation are over. Please stop the live streaming.
Pardon?
No, just saying to the presentations are over. Please stop the live stream.
Yeah.
This is stopping, sir. So the live streaming.